Hi guys, this is Jason Genin, and this is Dominic King. So we're glad to have you guys tonight, and we want to kind of share with you some of our thoughts and how we've been treating tendinosis and tendinopathy, and wanted to go over sort of the way we've been approaching it over the last couple of years.
Just say we're always pumped to meet like-minded people. So this is a neat format just to be able to meet the other people around the country who are getting into treating tendinopathies. This has been a great passion of ours for probably the last 7 years. We've had a lot of fun working together and developing some maybe novel ways of approaching tendinopathies, and maybe getting some people to think a little bit differently about how to approach tendons as well. So for our agenda, we're going to introduce a novel approach to the evaluation and assessment of tendinopathies, review what we have at the Cleveland Clinic as our classification that we've been using, and in that classification discussing where the role of minimally invasive tenotomy, MIT, is. Some of the tips and tricks that we've learned over the last 5 to 6 years treating with minimally invasive tenotomy, and then we'll introduce what other webinars we're likely going to have with Tenjet going forward, and then open it up for question and answers. So like always, let's go ahead and start with a case. So if this is a 45-year-old man who comes in with atraumatic lateral elbow pain, he's got normal x-rays, he's tenderness to palpation at the lateral epicondyle, he's got pain with resisted middle finger extension, no radial-collateral instability, no radicular symptoms of posterior interosseous neuropathy. And if we ask what is this, pretty much everybody on the call would easily be able to pick up, right? This is tennis elbow. We see this a lot. But the question is, what do we mean when we say tennis elbow? You know, eponyms are great for being able to talk to one another and have a good feeling of what the diagnosis is. But if we really get down to the pathology of what this means, everybody has maybe a little bit of a different thought. Some people feel that this is tendinitis. This is an inflammation of the tendon, and that's why it hurts. Other people feel that it's completely devoid of inflammation. This is just a degenerative process that happens because of overuse over time. And some people feel that there may be some components of tearing of the tendon, partial tears of the tendon or larger tears within that tendon. And it brings up a bigger question of, how do we classify any tendinopathy? Do we think of them as inflammatory, degenerative, or partially torn tendons? Are there certain tendons that approach to the office in a more inflammatory state? And which way would we use to diagnose these kind of tendons? If you look at the inclusion criteria of most studies, and this is kind of where a lot of our thoughts came from, take orthobiologic studies or really any therapy, most of the inclusion criteria for tennis elbow involves somebody that has greater than 3 months of lateral elbow pain that's not responsive to conservative treatment. And you see this across all the literature, and from our standpoint, I don't know that this really gives us a good look of what's actually going on with that tendon. So if I had 2 tendons that came in, one that was significantly inflamed, another one that was degenerative, and the third one that was torn, and I threw the exact same treatment at them, I'd expect to have inconsistency in results. And that's one of the things that we see in a lot of the research. We want to move from calling things, you know, this big general kind of lateral elbow pain or even tennis elbow, and move past just the term of chronic tendinitis or tendinosis to the potential of maybe even considering to call tendons type-specific tendons. So what we have is a type 3 tendinopathy of the common extensor tendon. What that might have in terms of outcome, what that may change in terms of research. Because a lot of the times we focus so much on the treatment, and we want to apply a new treatment like MIT to chronic tendinitis. And as we tell our fellows, and why we tell our colleagues, and we think every day, in order to understand the treatment, you have to understand the underlying tissue. If we just look back the last 30 years of tendinopathy, before 1990, treatments that we had were based around tendinitis. So we would use things like therapeutic ultrasound, KATSU, which later becomes BFR. Corticosteroid injections were around in the 1990s. And then heavy load eccentrics, the Alfredson's model for Achilles came out. Extracorporeal shockwave treatments, shockwave came out, and obviously we were still using steroids. We moved away from tendinitis a bit in the 2000s moving more to a degenerative type of condition. A lot of the glycerol and trinitrate patches were used, especially for Achilles. BFR became the new version of Katsu, and then corticosteroid injections obviously were still used then. And then orthobiologics came in the 2010s. Treatments like Tenjet, MIT, came around, and corticosteroid injections clearly are still a cornerstone of a lot of tendinopathy treatments in the office. If you look at that, we have about 30 years of new developments in tendinopathy treatment without really any significant development in how to classify that tendinopathy. So we use tendinopathy as being kind of the umbrella term, but what exists underneath that? If you look at normal tendon on one side and a ruptured tendon, completely ruptured, completely disintegrated tendon from end to end, what exists in between it? Most of us would agree that there's some form of inflammation and degeneration, and then also tearing. And there's some debate about tearing. How do you classify tearing? You could say that there's a partial longitudinal split tear or maybe an intrasubstance tear. You could have partial thickness transverse tearing, or you could even have full thickness tearing. So there's some debate in terms of what tearing means. But if it's a non-torn tendon, what's involved there? You could have inflammation on ultrasound, as we're going to get into, and Dr. Genin's going to expand on hyperemia that we see on ultrasound. Tendinosis, this degenerative type 3, type 4 type of collagen that replaces the normal tendon structure. We can see a mix of those types of tissues. We can see the fascia thickened because of overuse over time. Specifically for the rotator cuff and also the glutes, you can see intratendinous calcification. We can see tethering of the Hoffa's fat pad, Kager fat pad, topics that we'll likely get into in future webinars, really drilling down into the knee and to the ankle. And you can see tendon instability, long head of the biceps tendon and peroneals. If you look at just this sector, this has absolutely been dominated by corticosteroid injections throughout the years. Our surgical colleagues that we talked to identified this group as probably the most difficult to treat. You know, somebody comes in, hardworking guy, who feels a pop in his shoulder and he tore his rotator cuff. He's got no fatty infiltration of his supraspinatus. That's a great case, right? But somebody comes in with this chronic degenerative type of tendon, that's a really hard case to treat, especially from a surgical only practice. And these tendinopathies, we really do feel should be managed by physicians who practice what we call interventional orthopedics, the bridge between non-operative orthopedics and surgical orthopedics. And this is what we do consider to be, as we said in the title, kind of tendinopathy 2.0.
So, you know, thanks, Dominic. So this is Jason Genin again. So just a couple things. Make sure that you guys are, if there's any questions you have tonight, please make sure you just write them on the questions, and we'll be sure to answer just about anything to the best of our knowledge. You know, and we want to reiterate that what he just kind of gave you as a description there. When you have a patient that has, for example, a tendinosis that is degenerative type with a normal muscle bulk, but then the fatty atrophy tendinosis, that may present oftentimes in our clinic as the same thing. We all know that it's a completely different treatment algorithm, and that's what we want to get granular on, is really taking a look at how we're diagnosing these and just not saying, you know, these are all just tendinopathy. So for example, we wanted to see what on ultrasound, what we as experienced users can differentiate on features of tendinopathy. So we know that if you see on the screen on the top left, we can see a normal tendon there. We see a normal tendon and we can outline the features. And if you have the double line sign there just above the markers, you can make out the fascia just above it. And so we look and see if the fascia is thickened. You know, we want to look and see really what the features of this tendon is, knowing our sonoanatomy. So on the top right, you see a very classic case of hyperemia. And this tendon is, we understand that, is it full of VEGF? Is there signaling inside that tendon that's maybe making it into it's changing the morphology of the tendon? Is it changing its tensile strength, which you'll see in a little bit as we go to an intracontinent model. So as we move along, we can see that the tendon can also become degenerative. And so a degenerative tendon, as you'll see here as we're highlighting, it doesn't look quite the same. It's not got the normal tendon fibrils that we'll see. We have to be able to differentiate as well, looking at different structures. And some people will call that entire thing tendinosis, and we have to be careful with the most inferior portion of this elbow to look at the radial collateral ligament. So again, knowing sonoanatomy is really pretty important. And then you have these features of these patients that come in and they kind of have both. And so this was sort of born out of the fact that Dr. King and I were seeing a lot of these patients, and a lot of times they had different features, but every single one of these was called tennis elbow. But as you see, they all look different. And so as expected, the outcomes were different. And that more than anything else frustrated me. And so I wanted to understand a bit better why we were treating these things and how we can make changes. So this has sort of led to a process that's been quite pleasant as we've kind of evolved. And so what we asked ourselves is, can we reliably identify these findings? So we did a study, and we took 6 readers. We had 2 MSK trained radiologists. We had 2 fellowship trained sports medicine physicians, and we had 2 novice sports medicine fellows. And so what we did is we took 50 common extensor tendons that we had the full cine loop evaluations. And what we mean by that is we had several hundred pictures that were played in a full video. And we took 2 separate reading dates, and we randomized the order, and then we read them again. So we read each of the 50 cases twice. And so what we looked at was we wanted to see if we can find negative or positive. So negative would be minimal, and positive would be greater than what we consider minimal of the finding as noted below, and that would be tendinosis, hyperemia, tearing, enthesophytes, fascial thickening or scarring, tendon thickening, and intertendinous calcifications. So what we did, and we took this study, and we found that we were actually near perfect on both tendinosis and hyperemia. There was probably, as expected, some variability. And when you look at ultrasound identification of hyperemia and tendinosis, we were really good with this. Again, near very perfect. And this has been submitted for publication, which is good. To our knowledge, this is the first sort of study to evaluate these findings together, to try to kind of put it together for us to help substantiate what we're doing. We will note that there wasn't always the greatest agreement on things like tearing and enthesophytes, etc. But we do think that comes with experience. And as you get more experience and more comfortable, you'll pick out the minutia of what you're treating. But again, we'll question, does that really matter? If we're really good at seeing tendinosis and hyperemia, can we make treatment recommendations based on that upon a clinical exam and upon our ancillary testing that goes along with it?
So that's led us to understanding that there is reliability to find at least tendinosis and hyperemia. And for us, that kind of opens up a new world, right? For all of us who treat tendinopathy, rather than just seeing the tendinitis or the tendinosis that comes in, this maybe gives a little bit of a nice placeholder, right? If we can tell that there's differences on ultrasound, maybe we can put together a model that explains why patients may come in with different symptoms, and maybe even a classification for how to say this is a type 1 or a type 2. We do feel that the variability in the symptoms that patients come in with their variability of their imaging findings and the variability of their responses exist as a direct relationship to the variability of what we call intratendinous content. And this is what we mean. If we take those 4 pictures that Dr. Genin looked at before, and we take a cross-sectional kind of character model look, let's say this is a normal tendon. So it's a cross-sectional area looking at these normal tendon fibers, right? Then a hyperemic tendon would still have plenty of good fibers in them, but they would also be constituted with these hyperemic fibers, this neovascularization, these new blood vessels that are arguably very tenuous, but clearly taking up space in the tendon, possibly resulting in some swelling of the tendon, but definitely some different symptoms in a very different looking tendon than the first one. On the flip side, a degenerative tendon would still have good fibers throughout, but have these degenerative features as well. And then, of course, you would have a mix between these 2. If we only look at these 4 as being 4 different types of tendons, we would expect that treatments given for each one could potentially be different and be variable. So we'd love to see a study that was done on MIT of just patients who were 3s or patients who were just 3s and 4s, because this is where we feel that MIT may have the greatest significance. And so based on this, we developed a classification.
Yeah, and so what we're looking at is we went back and forth at least 100 times to see what sort of classification system we can come with. And what we wanted to do is we didn't want to necessarily make it an escalation. We wanted to make it just by what you're seeing and what the diagnosis is. So from an ultrasound standpoint, the Genin and King GK tendinopathy classification, a GK type 1 is simply that. You have negative for tendinosis and negative for hyperemia. That doesn't mean that you can't have fascial scarring or a partial tear. So that could be a GK type 1 with fascial scarring. But from a tendinosis and hyperemia, it's negative, negative. GK type 2 is negative for tendinosis but positive for hyperemia. We may think that this means something more clinically, like the acutely very swollen patient, acutely very sensitive patient, but it doesn't necessarily mean it's a stepwise progression in their severity. It's how they are presenting now, and it's what you see in front of you. And so these patients are typically burdened with quite a bit of hyperemia in their tendon. So a GK type 3 is the opposite. It's that kind of, maybe it's a burned out tendon, or was previously hyperemic, and if we understand it through the progression, it's now become a degenerative or kind of quiet from an inflammatory standpoint. And now you have positive for tendinosis for negative hyperemia. And I want you to think about these couple that we looked at. This could be sort of how we're describing the ineffective results sometimes of our other standards, which have been orthobiologics. You look at studies, they haven't gotten granular, in our opinion, necessarily enough to look and see what the actual tendon looks like. So in this case, again, it's more tendinosis than it is hyperemic. And then you have the type 4, which is both what we would call the acute on chronic, perhaps. And that's the both positive for tendinosis and positive for hyperemia. And in this way, we've been able to collaborate in a much different fashion and make some treatment decisions based on what we're seeing. And we feel very strongly that GK type 3s and type 4s fit perfectly to restructure the tendon with the percutaneous tendon debridement or minimally invasive tenotomy.
And so to jump in, as a real world example, we all know patients who come in with tennis elbow that in the past, maybe before you got into considering using MIT, had a corticosteroid injection and said, I got to tell you what, doc, it was fantastic. I got 5 years of relief out of that steroid injection. You know what, I just want another injection. And you give it to them, and then they're back in your office in 2 weeks. So what happened? Initially, they had to have a true inflammatory tendinopathy that was taken care of by the steroid. But eventually, it became a degenerative case that a corticosteroid, an anti-inflammatory, didn't work for. So in that case, was that patient originally a type 2, and then they presented back either as a type 3 or maybe a type 4. Maybe that steroid did work for a little bit, but then because of the degenerative features underneath it, that came back. That's what we're trying to at least get our arms around and separate out those tendons instead of lumping them together.
And to go back just to add upon this, and I think this is really important, what he said makes total sense here, is because you will get those patients that last for so long with the inflammatory. You know, you give them a cortisone injection, or you give them a prednisone burst, or whatever clinically you decide is relevant and appropriate. They last a long time. Then the second time it didn't work as much. So I want to try to open our eyes to think that maybe the tendon changed. Maybe the quality of the tendon has changed now, and so that makes total sense for us.
So when that quality of tendon changes, right, this is where we found when we were first introduced to minimally invasive tenotomy, we've been waiting for something for these treatments of patients, right? The patients who come in, you've given them a counterforce brace, let's say just a common extensor tendon. You give them a counterforce brace, you do a bunch of eccentrics, they do rice bucket therapy, they do great PT, they changed their activities, they took anti-inflammatories, they had corticosteroid injection, then they had another corticosteroid injection, and then they come in and we see the lack of hyperemia, or at least the preponderance of tendinosis, and we say, what do we have for that? This is where this has really come in to change our practice, and this is outside of being just from Tenjet and being a webinar that you're on from here. This has changed our practice. This is all we see now. We have Tenjet forward practices. We do about 200 of these procedures a year, and we'll talk about that in just a second. But this is our favorite thing to see in the office now, and our surgical colleagues say, we're glad because it's probably some of our least favorite to see. So we're glad there's docs like you that can take care of this. So this is a video that you can see on Tenjet's website. Goes through a procedure. They're in the office. This is in a procedure room. We do a local anesthetic injection, little 11-blade small puncture. We inject a little lidocaine with epinephrine to help with bleeding there. And then the device is inserted in through that under ultrasound guidance. This nice cartoon kind of shows you how it works. You have this jet of saline that causes this venturi suction, pulls in this more tenuous kind of mucousy degenerative type 3, type 4 collagen. That's that GK3, GK4 tendon, and debrides it out. And again, nice character overview of what you're looking for is trying to resolve these thickened tendon areas to return the tendon to be able to linearly load again. So it's improving the overall tendon structure. We're not trying to regenerate tendon tissue. We're not trying to provide a healing environment like a orthobiologic says it is. This is a mechanical treatment for what is otherwise a mechanical problem. So a great way to describe this is to look at calcium deposits. So for those of you out here watching this and you understand sonoanatomy, right? This is a subscapularis tendon. Up front, as this comes in and out and rotates in, we can see the biceps groove, the biceps in its groove, and we see our subscapularis tendon. And for any of you who've seen calcium deposits, this is a honking big calcium deposit in the subscap. What you can use Tenjet for, very simply, outside of just removing tendinosis, probably the most impressive ways to show patients that they're getting better during the procedure. Here's the device coming in from the left side, coming right into that calcium deposit. You know, no large incisions are made here. We're not going in with a shaver arthroscopically and, you know, putting a grenade in here. We're going in with laser precision and breaking up and debriding out this calcium. And for anybody who says that, you know, you can't remove calcium deposits with here, here's the large calcium deposit after it settles in the bottom of this container. And if you want a patient who can buy into a treatment, show them they're getting better while you're doing a procedure. They're numb, they're awake, they're watching the procedure being done. We let this settle in the bottom. We show them, here was why you were having pain. Immediately after the procedure, we'll go get an x-ray. On the left, you'll see the pre-procedural x-rays. You see this large calcium deposit that actually wraps all the way around the subscap and over into the biceps groove. And over here, complete resolution of it. Not a piece of it is left. This is a large study that we're finishing up in terms of a retrospective look of how we used to treat calcium deposits with one needle barbotage with corticosteroid injections, and then the value that percutaneous and minimally invasive tenotomy has given us. And this is the reason why we say, if somebody asks, what are you doing? What is MIT actually doing? In our practices, we say that role is decreasing the intratendinous load of degenerative tissue to enhance the tensile capacities of the tendon. Tendons are made to attach muscles to bones. It's what they do. And they need to pull in one direction. And if they're not pulling in that direction and there's an intratendinous force pulling it somewhere else, that mechanical force needs to be removed in order for that tendon to function normally. That's as simple as we can make it, and it's a very logical, conceptual way to explain what MIT does.
And so again, that's fantastic. I think what we've seen is we are now looking at these for GK3s and 4s, right? So we're looking mainly at the tendinosis or more inflammatory upon tendinosis. We've done over about 1,000 of these cases so far, and we're really we're trying to be granular again on our tracking on this. So we're tracking patients at 0, 3, 6 months, and a year. And we're looking at all the conditions that you've seen above. We've done multiples on all of them. And so what we're trying to do is we're trying to focus on how we can make a different protocol for each one of these, understanding both the clinical presentation, the needs of the tendon and the joint that's involved, and then how we can appropriately load the patient and get what we call minimal touches. But we want to decrease the overall amount of visits we have with the patient, but give them quality care and quality information rather than just bring them in and out. And so our early data suggests that our average decrease in symptoms for all these combined will typically be about 4 to 6 weeks. And sometimes we understand that, especially for certain situations, which we will go into further with both future webinars and any questions you might have, some of them take a little bit longer. So we're setting the patient up with that from the beginning. So they have the expectation that this isn't going to be better tomorrow. The biggest thing that we've seen, and the kind of prominent feature that we've had is the patients we've decided to take to minimally invasive tenotomy, less than 8% have progressed to surgery for this. And to us, that's fantastic news. And it tells us that what we're doing is quality work. We've had no tendon ruptures.
And I got to break in here. We absolutely thought we were going to get tendon ruptures. When Jason and I originally were talking about this, and we were talking with our surgical colleagues, there is no way we thought we were going to do the number of Achilles, the patellar tendons that we did, the rotator cuffs, and not end up with a large amount of ruptures. And I think we owe that a lot to maybe the approach, but also the pre and post-procedure rehabilitation protocol. That's something that I don't know that we've focused on that much in the past, especially if you go to any of these like orthobiologic conferences, you ask about post-procedure rehab, and it's, load them up when they're ready, let them go. I think that's something that Dr. Jen and I know has taken a big interest in future webinars. We're really going to focus on is what is that post-procedural rehab.
And so we again, we're analyzing that data, and that's really important to us. So some of the tips and tricks, we feel that ultrasound training is a must. We know that all the physicians on this call, you guys are all really good at clinical assessment and treatment of your patients. To do this, I do really think you need to feel comfortable having significant experience, understanding the variables that you're going to see in each tendon, each myotendinous junction, each fascia, each overall joint, and the tendons for the joint-specific areas that you treat. We kind of suggest that you're getting in those 50 to 100 evaluations. Feel comfortable doing it. Kind of push yourself. Do as many as you can. Feel comfortable with taking care of that patient, and use your adjunctive treatment. That may be MRI for you in the beginning, and how to correlate the ultrasound and the MRI together. We find the ultrasound to be quick and inexpensive. It's easy for us to perform, and you can do bilateral evaluations, and they're dynamic, right? And so what we're starting to see, especially for the rotator cuff, we've shown now for the elbow, and patellar tendon, et cetera, that we feel that the ultrasound, and again, I use this word several times tonight, but it's much more granular when it comes to focusing down on the tendon itself than likely the MRI in the experienced hand.
I think a lot of times we'll pull up a MRI of an elbow, and it'll show, increased signal at the common extensor tendon, and depending on the radiologist who reads it, some of them may call that a partial tear. Some of them may call significant inflammatory tendinitis. Other people will call it tendinosis. But it's an MRI of the whole elbow, right? If you zoom in on the common extensor tendon on even a T3 MRI, it just looks like a blob with a white line in it. You get an ultrasound of it, you can see layer by layer, just as we showed you before, of the fascia, the hyperemia, each one of the tendon fibers and the tendinosis. So the ultrasound for tendons, there's no doubt that it's superior to being able to show non-ruptured tendinopathy better than an MRI.
And so we're really kind of focusing on those significantly degenerative tendinosis, or the tendinosis with hyperemia, so the GK3s and 4s. We probably would advise that if you've given a recent cortisone injection, either under ultrasound guidance, and especially if you've given it blindly, to wait at least 3 months prior to proceeding with the tendon debridement, the MIT. We feel that it's important to likely have a separate day for Tenjet. We feel that that's been most successful for us, where we focus on doing those cases in a day, and we'll have a day we'll do about 10 to 12 cases. And if the staff feels comfortable with the turnover time, but again, that's provider specific.
And I'll say, a lot of us don't come from a surgical practice, right? We're primary care sports medicine docs, so your staff may not as well. So if you have a procedure room that you're doing this with, or surgery, you're going to want to rehearse as well, right? Let everybody know the steps of the procedure. Even something that you can put down on a piece of paper and say, here are all of the steps. And we say this seriously, think like a surgeon, work like a surgeon. Our director of orthopedic surgery looks at our practices as mini surgical practices. We book cases ahead of time on one day. We run the room as if it is a surgery. The room is prepped. It's sterilely prepped, even as a procedure room, the same way a surgery is. And we're valued in the department just in the same way that any of the surgeons are. So, I mean, this is a nice procedure to roll into practicing that way.
So what we really kind of, we really advise the patient, again, these are kind of little tips and tricks type stuff, but we advise the patient that, when they come in for the procedure, we try to make it as comfortable as we can for them. And we're really big on the post-procedure rehabilitation concepts, right? And so we think that it's important to tell the patient that not only are you getting the procedure, but what it's like to expect in weeks 1, 2, 3, and 4. Again, that might be a little hard to expand upon now in this talk today, but as we get through further webinars, each tendon poses a different concept. We'll take a lateral elbow, for example, since we focus on that tonight. We often wear a wrist brace for a few days, a wrist extension, a cock-up wrist brace. Then we'll wear a tennis elbow strap after that for tendon load. And then weeks 1 and 2, I allow a concentric to eccentric ratio of 1 to 2 with multiple doses to try to fatigue out any of the degenerative tissue that we've removed to allow appropriate enhancement of the normal collagenous tissue. And then we increase that load as the weeks go on. So we've done this over time and feel comfortable with making these recommendations, but we think that's really important.
And then finally, definitely working with your surgical colleagues. They're probably one of your best referral bases. Most people think, family medicine, have them send over tendinitis, send over your tennis elbows. I'll tell you, if you go to your local, even the total joint guys who see a lot of gluteal tendinopathy, your hand and wrist surgeons, the sports medicine docs, just go to them and say, what are the cases that you don't like taking care of? What are the hardest patients you take care of? Across the board, outside of osteoarthritis, right, the patient's not ready for surgery, the main thing they're going to say is chronic tendinosis. Or you could educate them and tell them how much you love taking care of chronic tendon problems, because they're going to have plenty of patients. We do not really market ourselves in the Cleveland area because internally, it's very easy to get the referrals from our surgical colleagues. And if you're looking at kind of breaking in, if you're somebody who's currently not with an orthopedic practice and you have orthopedic practices in your office, going out and letting them know, I look at tendons in different ways. I diagnose in different ways with ultrasound. You do not need to get MRIs to be able to send patients over. And we have a new procedure that we do that's less invasive, that we have great success with across the board for these common tendinopathies. And we would love to offload the degenerative tendinopathy of your practice to get you more appropriate patients. And if they fail this, it doesn't keep them from getting a larger surgery if they don't get better. But the second that you tell somebody that you take care of tennis elbows, gluteal tendinopathy, and plantar fasciopathy, your schedule's filled, because there's plenty of orthopedic surgeons who need somebody to take care of that, rather than just our physical therapy brethren who do a great job loading and rehabbing tendons, or some of our other colleagues who do pretty much maybe blind injections. The skills that the people have on the line right here may not fully have been valued yet. Being able to use ultrasound to just guide injections, taking that next step to doing MIT really solidifies what interventional orthopedics is.
So in the future, our hope is to provide several of these kind of breakout sessions where, as you see on the screen, we want to do upper extremity, lower extremity, foot and ankle, and we want to get very in depth on the approach, the setup, the recovery, in the expected outcomes. I think that would be really good for us to kind of go from that from a step by step, and that'll probably produce great questions and give good feedback, and as we hope to provide that in the very near future.
Yeah, the nice thing about each one of these webinars is taking a deep dive into each one of these tendons, and not just saying that we treat all upper extremity tendons the same. What are the specifics about common extensor tendinopathy? What are the specifics about the rotator cuff, about calcific? What is a squeeze test for patellar tendinopathy? What's the squeeze test for the Achilles tendinopathy? What's the hydrodissection? We're not just jumping in to talk about MIT for each one of these. It's a comprehensive approach to how to treat tendon and where MIT likely fits best, and then where the post-procedure rehab for MIT likely lives, and how to sequence those patients appropriately. So I mean, we thank you guys for jumping on the call. We're right at about 35 minutes of getting through this. We want to open this up for the potential for questions